I think I'd add a third word to the freedom versus liberation, and it's security. I think what I've learned the most in my practice, which is very different than Josh. I'm really an individually oriented practitioner, though I see families and I think in those terms. I don't do work in the community in a public health framework. And the choices to be made in the care of the chronically ill and people with mental illness and drug abuse also relates to the obligation or the question of the obligation for protection and security. And I think one of the, will be very hard for me, is not to honor the individual's autonomy. And so whereas your story is a cautionary tale, it's also a choice we make, which is that at some level, the opportunity for individuals to find their way and to not discredit that by the terminology of illness is a challenge. But I think that would be my personal lesson in terms of doing this work. The other would be the struggle for people of consciousness in care to struggle around social medicine, to struggle around how we all embrace the idea that you can't find a better Meyer-Kaplan curve than you put up there. There's nothing, that even from just a survival point of view, there is no chemotherapeutic agent. There is no medication that separates out treatment from an untreated group like what you've defined.
So I think this balance between beneficence and autonomy is a really challenging one. So I think to answer your question first, I think, and I don't mean this to be disingenuous because Jeff's known me so many years, I think humility is the key to knowledge in medicine. And I was thinking about, you know, all these TV doctors who come across as so arrogant. And when you have to make a decision where you really don't know what's going to happen after you give someone medicine, it's a real kind of a crapshoot a lot of the time. You have to come across like you know what you're doing. But I found that in taking care of people with severe poverty, the necessity for just acknowledging what we don't know and having humility around it is really critical. And then the other part is, well, two other things. One is having people who you work with who really line up with your values and your commitment to social justice. We have such a wonderful group of people who I work with. And, you know, we see so much sorrow and suffering every day. And I have no doubt that we could not continue to show up every day and provide the love and tenderness that we do without having a group of people who really support each other. And then lastly is not being afraid of being in the midst of it. And this is, I don't know how many of you feel this way. There are so many people who suffer every day and so many more outside of this country than are suffering here. And people often say, you know, how can you tolerate that? My feeling is, how can you not do something about it? It feels so much better to try to do whatever little we can to help alleviate people's suffering than it does to just turn our backs and do something else. So whether it's by giving to other people through tenderness or stuff, or by trying to find ways to heal, it feels so much more to be active, even if it puts us in the center of the tornado of suffering. So those are those three things. Get that question?
Yeah, that's very nice. And it moves into another question about where you find your own inspiration and strength to keep going when the odds seem to be against you. So
from my mother.
So we have two questions related to nature, and maybe actually three. So would you be willing to talk about the role of nature in well-being, and how the location, the surrounds of your building, in so much as they're in contact with the natural world, impact your patients' outcomes?
Wow. I mean, I don't know. Again, the data that I showed you is, I tried to be really data-driven and not necessarily building on hypotheses. As I said, the hypotheses generate from my own personal experience of seeing beauty in nature that seems to really make me happier and healthier. The data seems to support that the more safe a neighborhood is and the better the architecture is, the more powerful the outcomes are. But I don't know if we could extrapolate to nature from that. I'd like to think that, but I think it's really important that you don't get out on a limb away from your data when you're trying to do advocacy. This is radical stuff, right? The idea that housing is healthcare is, wicked radical, as they say in Boston. So to go further and try to incorporate what things that make sense to me, but I don't have any data for, I think just puts you out on a limb, and then you end up having the limb break off. You had a question over there.
One thing you said was look at these buildings, and the difference in Mission Bay, for one thing, is it's surrounded by water. There's water there. I didn't see it with the other buildings. Just
Right.
concrete, like,
Right, it might be the water, but I don't know. It could be, and I appreciate that you noticed that. Let's embrace that, but let's also, evaluate it. So we'd have to have a couple of buildings that are separate from one.
There's simple research, and it's not great research, but about use of pain medication and time to discharge when the window of a hospital room looks out at trees and nature as opposed to a parking lot. And there are systems, usually European systems, that have a creative design and will incorporate natural elements within the, I don't know that that's researched, but there certainly are places, and it'd be interesting to see if at some point the grant, which allows you some social construction of these facilities, to see what happens if there's a garden, or if there are elements like that.
Yeah,
that
we have
make
two
an
buildings that have a lot of balcony. One is called Parkview, which is on Franklin and Turk, where Libby goes twice a week. And the other is this building called 990 Polk, which is on Polk and Geary. And each of on the 8th floor of Polk and Geary is a community garden that is really lovely. It's made in cement blocks, but it's really cool design where, the water will flow through and then get recycled, and it's just a lovely little place. And they also have very good data there. Ms. Bailey, you have a question there?
Question, but just a comment that when I worked at the Windsor Hotel, someone who wasn't doing very well moved into one of the other concrete buildings, the new buildings, the plaza, and I went to visit her. Now, when she was at the Windsor Hotel, which is one of the ones where people die more, when she was there, her room was just a mess. When I visited her in the newer building, it was absolutely beautiful. She went and she bought things very cheaply, but she had it decorated really nicely. And I asked her what made the difference. And she said, I feel really pretty again. She really connected with this building, this room, her space was pretty. And she was reminded of how pretty she was. So she manifested that on the outside. And, it wasn't even the Mission Bay, it was that space. And, she taught me something about that.
Nice. Yes, sir. Yeah.
There's a lot of evidence on social connections being kind of related to quality of life and mortality. Are the different facilities that you see, like the more beautiful facilities, are the social connections deeper for the populations, or has that been
I don't have any data on that, but it's certainly my experience. When Mission Creek has a community gathering, and they have them almost every week because it's such an incredibly multicultural community, and that building is also mixed. As I said, it's 54 units for chronically homeless seniors and another 110 for low-income seniors. So they have people from Burma and from Thailand and from Scotland, and I just think they have flags in their common room representing the countries where all the people who live there come from. And when they have a community meeting, it's rocking. And when we have a community meeting at some of our other buildings, it's rocking in a different way, but not so much around community. And the one guy who almost got evicted from Mission Creek, who went on a binge for alcohol, came down to the desk clerk and got in some sort of argument and punched the desk clerk in the nose. And so we started eviction proceedings. And basically everyone in the neighborhood around him said, "What did you do that for? Will you please get sober?" And he said, "Okay." I mean, that's really different than what happens in some of our other buildings. So I think that sort of setting a different bar for acceptable behavior because the community standard is different is what leads to those reductions in move-outs, reductions in evictions. And I think also leads to mortality improvement. So we don't have those measures, we only have these proxy measures, but I could definitely draw a dotted line to those things, and it would be great to have some way to actually establish that in the literature.
Do you have a contract for residents to sign, or
everyone has
rules and
tenancy
regs?
rights. For those of you who rent, it's the same boilerplate that you sign. You know, pay your rent, don't burn the place down, don't sell drugs in the lobby. Yours might not say that, but it's implied. So that's pretty much, you know, it's hard to get evicted. They have tenancy rights, and it's a court proceeding when people are moving out. So they have to do some pretty egregious things.
And are there those who do prefer the street to housing?
It's not my experience. My experience is there are people who prefer the street to some of our renovated SROs, but I haven't come across people who prefer the street to what the decent housing that this country is capable of.
Okay, good. So we've got housing as healthcare, we know education is healthcare, we know violence reduction is healthcare. If you were a healthcare policy maker, what would be 3 to 5 priorities that you'd like to see changed in the way the U.S. provides healthcare?
I'll use my experience in integrative medicine, where the language of insurance coverage for much of what we do doesn't exist. So it's going to be an out-of-pocket for supplements or nutrients or even nutritional counseling when it's not provided by a registered dietitian. And so one thing I'd like to see is that meaningful healthcare interventions are covered in the system, and we don't differentiate procedures and medications, because there's so much that's available for people that would be effective. So this is kind of skirting the depth of what you're talking about in terms of social medicine. But this is really to open up the idea of what constitutes meaningful healthcare. And so part of it would really be making accessible the wide array of things that are reasonably evidence-based, so that there's legitimacy to their efficacy and their safety, but that it's a much wider opportunity for people to explore their health care needs.
I think the first thing I would do with healthcare reform is pretty much what's part of the Affordable Care Act, which may be undermined or dismantled soon, is to get rid of these perverse incentives where the system pays for people to be sick. And the sicker you are, the more money comes into the healthcare system. So this fee-for-service idea is just backwards. And it's not just paying for prevention. It's also just stopping this whole escalator that leads us to pay for sickness. So a universal healthcare system where nobody pays for healthcare. I think, you know, the argument that's been going on in the Supreme Court, I think, is the argument that the right has come in is actually legitimate, personally. I think, you know, forcing people to pay what they've earned for other people's sickness is not something that should be an individual choice. It's what government should do. So I think one of the reasons why I'm somewhat looking forward to the Affordable Care Act getting undermined by the Supreme Court is because we didn't go far enough to do what every other country in the world does, which is to make healthcare a right, not a privilege. And if you have to choose to pay for it, then the whole system is perverse. You end up paying people, reimbursing the system when people are sick, instead of saying this is what you should get, and whether you get sick or poor, or sick or well, the cost doesn't change. And that's how a universal healthcare system needs to be. So that would be the first thing I would change. And then I think the second thing I would change is that we really have to not be embarrassed about giving people who need it things that are potentially expensive. So one of the questions that often comes up when I present these data is, what about the poor African-American woman with 3 kids living in the Bayview who gets up every morning at 6 o'clock, drops her kids off at daycare, goes and works her day job at McDonald's, and goes and works her second job cleaning an office building, comes back to see her kids just as they're, you know, already asleep, just so that she can make just enough to pay her rent, while someone who's a heroin-using, diabetic, schizophrenic gets this beautiful housing. Is that just? So it's uncomfortable, right? So as I was preparing for my Seder tomorrow, I was reading this stuff that the Kabbalists say that justice without mercy is the cause of all evil. So is that just? No. But is it merciful? Yes. People who are living with bad illness need to get what the treatment is. And the treatment for chronic homelessness and mental illness is housing. If we give everybody this beautiful housing, then what's the incentive to make our society great? Now, where the bar is, I don't know. And I think that for someone who's living with 2 kids, 3 kids in the Bayview who have to struggle so hard, that's wrong. But we also need to have some way that so people don't just give up on their dreams to strive. And that balance is something that I'm not really that sure about, and I'd love to hear what you guys are thinking. I feel like I've stepped into something, and I'm ready to see what it sounds like.
I just have a quick comment on that last scenario with the single mother and children versus the addicted person with diabetes. Yeah, you could say that it's not just. However, knowing that those children will be alone after hours and knowing that there would be a potential drug user person on the street versus that person being indoors away from that traffic area where her children could possibly be a benefit.
Right, that's not very merciful either. Yeah.
You know, it could be a benefit to her children to have that person somewhere safe to, again, make it a tiny bit more safe for her kids.
Right. So it's a tough conundrum.
So if we're talking about preventative medicine as being more effective than treatment, and we're talking about housing as healthcare, how do we broaden the spectrum so we're not just talking about housing for the extremely, extremely sick, diabetic, unrelated, schizophrenic, heroin user, and we're talking about how do we get affordable housing to people like
the woman at the scrap. Yep. Right. So another way to think about it is the bang for the buck is with these expensive homeless people. So if 18% of the gross national product is being spent on providing health care services for people in this country, if we can reduce that to 16%, then that other $1 trillion, or whatever it is, can be used for these things that we need to be investing in: education, decent, affordable housing for everybody. So that's another strategy. But the pain to get from point A to point B is that some of these people who we all think we should be embracing with the best of affordable housing and education can't be done now.
There was the Community Health Acts of the 1960s and the development of centers that were really organized for underserved care had in it a fundamental principle, which was you can't have reform of a system like healthcare unless you have a movement. And so when Josh needs to use the language of housing is healthcare, housing is a lot of things. We don't plug into what's the bigger view of what our society is about so that the conversation about what money is available finds its place into the evolution of our lifestyles and the disbursement of many of the elements of a good life. Instead, it's about saving money so that the cost of government is reduced.
But we need to do that today. We need to pay attention to dollars.
No, I'm just saying that to really evolve the view of this so that it's not just about housing, it's about other things, requires a view of what we want, not just to save money to save money. It's your issue of if it's just silos, there's not a larger investment. And to really broaden this, a public health movement that looks at nutrition, that looks at housing, that looks at education, that is a model for what American development of this time is a requisite to really bring forth the vision that Josh is working on from a healthcare perspective.
But like what you mentioned so beautifully about what is healthcare, I think that's why we do this work, not because we're trying to reduce cost.
Yeah, no.
But the reality of today's society is we need to find ways to reduce our cost.
Yes.
And, this triple aims idea, right?
Yes.
You need to find ways to reduce costs while you're improving health. And if we ignore the dollars while we try to have our social movement, and I think that's one of the things that sort of undermined the war on poverty, is there wasn't enough attention to quality and expense. And I think we can do it again.
Well, let's hope so.
I don't disagree.
And with people like you out there, I think we'll be able to. Did you have something?
I have one more thing.
Yes, please.
And it's about Passover.
Dianu.
And it's about, and you know, 20 years ago, I would never have thought that I'd be talking about what Josh offers in relationship to the obligation of a Jew celebrating Passover. Because the requirement in this celebration is not to tell the story about a long time ago, but it's to look at the reality of freedom in our life now. Where are we free? Where do we need to get free? What's the source of our freedom? And to me, the beauty of this night with you, my friend, is to really look at what Josh offers as a lesson for all of us in terms of freedom. How is it that as a culture, as a society, as individuals, we follow the lessons of a Meyer-Kaplan curve in terms of a basic human need and right, an effective healthcare intervention, and yet also the key to us finding freedom as a culture and as individuals. And so my friend, thank you.
Thank you.
Beautiful.
That's beautiful.
And I would just like to put in a metaphoric word for Easter and for spring, because the metaphor of Passover around freedom, slavery, and oppression is certainly consistent with the metaphor of Easter and the possibility for resurrection and new life, and consistent with the metaphors of spring and rebirth and new growth and great possibility. So I would like to leave you with a few words from Dr. Venkataswamy of India, a sage and a mentor and somebody we had the great privilege of a few years ago to honor at the medical center, who said, as we grow in spiritual consciousness, we identify ourselves with all there is in the world. Then there can be no exploitation. It is ourselves we are helping. It is ourselves we are healing.